Welcome to this explainer. Today, we're diving straight into the fascinating and honestly rapidly evolving world of low-grade appendiceal tumors. Specifically, we're going to zero in on the management of low-grade mucinous adenocarcinomas of the appendix and its related neoplasms. Now, for literally decades, the medical community has wrestled with how to best treat these incredibly rare anomalies. But as you're going to see today, pretty much everything we thought we knew is changing. We're actively moving away from these aggressive borrowed protocols and shifting toward a much more highly targeted, biology-driven approach.
Get this, what's really staggering right off the bat is that the incidence of these rare tumors literally doubled between the years 2004 and 2017. We're now looking at estimates of nearly 1 case per 100,000 individuals. So what does this actually mean in practice? It means that clinical professionals, whether that's a general surgeon dealing with a total surprise during a routine appendectomy or an oncologist planning out long-term care, are increasingly likely to run into this exact dilemma.
To help us make sense of this shifting landscape, here is our roadmap for the explainer today. We've got 6 main areas to hit: the appendix tumor dilemma, classifying appendiceal neoplasms, shifting surgical paradigms, managing peritoneal dissemination, the chemotherapy question, and finally, a biology-driven future.
Okay, let's jump right into Section 1, the appendix tumor dilemma, and take a look at the historical problem we've been facing with this diagnosis. For years, because appendiceal tumors are just so exceptionally rare, we didn't have massive randomized clinical trials to rely on. So, what did the medical community do? Well, we basically borrowed. We extrapolated aggressive treatment protocols directly from colorectal cancer, essentially treating the appendix like it was just another part of the colon. But here's the crucial point. Appendiceal tumors, especially the low-grade mucinous ones, have an entirely different, highly indolent biology. They absolutely do not behave like colon cancer. And unfortunately, treating them as such has led to a lot of unnecessary radical surgeries and highly toxic treatments for countless patients.
That brings us to Section 2, classifying appendiceal neoplasms. Let's see how redefining the problem, both visually and pathologically, changes our entire game plan. Being able to actually visualize the disease fundamentally shifts our approach. Just take a look here. On one side, the CT scan reveals the actual mucocele. You can clearly see that cystic dilation of the appendix, which is caused by this huge accumulation of mucinous material. Then, right alongside it, the histological structure of a low-grade appendiceal mucinous neoplasm shows us exactly what we're up against on a microscopic, cellular level. Truly understanding this specific cellular architecture is the key that unlocks our new, refined approach to treating the disease.
Now, to make sure we don't get lost in all the medical acronyms, let's clearly define what we mean when we say LAM, M-A-N. It stands for low-grade appendiceal mucinous neoplasm. The real hallmark of a LAM is something pathologists call a pushing invasion. Unlike a traditional, aggressive adenocarcinoma that just destructively infiltrates through tissue layers and rapidly spreads to the lymph nodes, a LAM gently pushes against the appendiceal wall. Plus, it exhibits low-grade cytologic atypia, meaning the cells themselves aren't highly mutated or dividing wildly. It's fundamentally distinct from typical infiltrative cancers, which tells us that our defensive strategy needs to be fundamentally distinct too.
Armed with this new biological understanding, let's head into Section 3, shifting surgical paradigms. We're going to explore how modern surgical strategies have completely flipped from radical to restrained.
To really grasp how much things have changed, let's break down the patient cohort from a recent multi-center study that tracked 184 patients. Researchers wanted to analyze how different surgical modalities actually affected survival outcomes. So they compared patients who received local conservative resections, like a simple appendectomy, against those who received extended resections, which primarily meant a right hemicolectomy, where a large portion of the colon and the surrounding lymph nodes are removed.
And here is the absolute standout number from that data: a staggering 97% overall survival rate for patients who were treated with just a simple, localized appendectomy. When the tumor is confined to the appendix, simply taking out the appendix is overwhelmingly curative.
The outcomes here just clearly prove the point. While a local resection gave us that 97% survival rate, the extended resection actually showed a lower overall survival rate, dipping down to 79.2%. Now, why would a bigger surgery have a lower survival rate? It's not that the larger surgery directly made the tumors more deadly, but it proves beyond a shadow of a doubt that a right hemicolectomy does absolutely nothing to confer a survival advantage for localized LAM. Because LAM has that pushing invasion we talked about earlier, lymphatic spread is virtually non-existent.
Taking out perfectly healthy lymph nodes and sections of the colon just exposes the patient to severe surgical risks with literally zero oncological benefit. In this case, less is definitively more.
But as with everything in medicine, there are complications, right? Let's look at Section 4, Managing Peritoneal Dissemination. What actually happens when the tumor isn't perfectly contained in the appendix?
We have to remember that as these tumors produce mucus, the pressure inside the appendix is building and building. There's actually a 5 to 15% risk of the appendix rupturing. If that happens, the tumor can spill its semi-solid mucin right into the peritoneal cavity, that space inside your abdomen. This leads to a really dreaded clinical situation known as pseudomyxoma peritonei, or PMP. Having this vast accumulation of mucin in the abdomen vastly complicates the patient's prognosis and completely changes our surgical game plan.
The latest guidelines, and we're talking about the 2025 German S2k and the updated Chicago consensus here, synthesize exactly how we should handle this. For those early stages, like PTIS or PT3, where there is no mucin spread, an appendectomy alone is totally curative. Boom, done. Even for larger, completely resected tumors, as long as there is no mucin spreading beyond the right lower quadrant, an appendectomy is still the gold standard. No hemicolectomy required. But the game changes if mucin is actively present on the appendiceal surface or spreading. In that scenario, the consensus recommends highly individualized cytoreductive surgery, often paired with HIPAC, which is heated chemotherapy delivered directly into the abdominal cavity during the surgery itself.
Okay, time for Section 5, the chemotherapy question. And brace yourselves, because this is a major plot twist regarding the use of traditional systemic chemotherapy for this disease.
Because we used to treat this disease just like colorectal cancer, patients with appendiceal tumors often received standard, highly toxic systemic chemotherapy regimens. But according to the absolute latest consensus guidelines from the leading oncology consortiums, the ruling is incredibly blunt. I'll just read it. No evidence supports systemic therapy in this population at this time. Zero evidence.
A landmark prospective, randomized crossover trial recently put those older treatments to the test, and the results were completely definitive. When it comes to the management of low-grade mucinous adenocarcinoma of the appendix, or localized LAMN, fluoropyrimidine-based systemic chemotherapy offers absolutely no benefit. And if you think about the biology we just learned, it makes perfect sense. These tumors are low-grade, indolent, and incredibly slow-moving. Traditional systemic chemo is designed to target rapidly dividing cells. Therefore, putting a patient through all the debilitating side effects of systemic chemo for a low-grade tumor isn't just unhelpful, it's practically unwarranted by modern science.
Let's pull the whole shebang together in our final section, a biology-driven future, and see how all this builds a much safer, more effective reality for patient care.
We are looking at a complete biology-driven evolution when it comes to the management of low-grade mucinous adenocarcinoma of the appendix and LAM. By fully embracing this clean, four-step modern care pathway, we can dramatically improve a patient's quality of life. Step 1, properly identify that unique pushing architecture of the LAM. Step 2, perform a targeted, localized appendectomy, completely avoiding those heavy hemicolectomies if the disease is localized. Step 3, spare the patient from futile and toxic systemic chemotherapy. And Step 4, observe and monitor the patient with smart, risk-stratified surveillance based on their specific, individual clinical findings.
I'll leave you with this final thought to chew on. As we finally decode the unique, highly specific biology of rare diseases like LAM, and prove once and for all that less is often more, how many other borrowed medical protocols across the vast spectrum of oncology are just waiting to be completely overturned? Thank you so much for joining me on this explainer, and keep questioning the consensus.